All right, let's get started. Good evening. This is Dr. Eric Goldstein. I'm one of the gastroenterologists with New York Gastroenterology Associates. It's my pleasure to welcome everybody to our webinar tonight on overgrowing SIBO myths, nutrition and small intestinal bacterial overgrowth. This is going to be presented by two of our dietitians, Susie Finkel and Faith Aronowitz. Susie is a registered dietitian and New York State certified dietitian nutritionist specializing in the dietary management of digestive conditions and diseases. She works with patients on improving symptoms through evidence-based nutrition therapies and flexible strategies to support food enjoyment. She holds a Master of Science in Nutrition from Columbia University, where she also completed her clinical nutrition training and is a graduate of Skidmore College. Faith is a weight-inclusive registered dietitian specializing in gastrointestinal health and eating disorders. Faith has experience working with inpatient and outpatient behavioral health populations, previously working at the New York State Psychiatric Institute and as part of a group eating disorder practice. Faith earned her master's in nutrition and exercise physiology from Columbia University and a bachelor's degree in theater from Muhlenberg College. Very proud to say that they're both here with us now and doing a fabulous job, having trained with Tamara Freiman in my office before we all joined NIGA. And tonight's kind of like watching the kids grow up and fly on their own. So I'm very happy to introduce this topic. Before we get started, just one little or two little housekeeping notes. I will be here monitoring questions. There's a Q&A button on which you can submit questions. I'll try to answer them as we go along. Some of the really good ones questions that are repeated very often we'll save for sort of more public discussion at the end. They'll be posed to our speakers. Please be advised that when a question gets answered, it is made public, so I will not be responding to any personal individual questions about anybody's own healthcare. And with that, let's get started.
Great. Thank you all for joining. I'm gonna just go over our fun agenda we have planned for this evening. We'll be talking about what SIBO is, a introduction, what it feels like, the risk factors. It's important we have an understanding of that before getting into the nutrition piece and to best address your questions. We'll be talking about nutritional strategies for SIBO, the popular diets and whether they're effective or not, supplements that may or may not to help manage SIBO-related symptoms, and then we'll get to any burning questions. So first, let's spend some quality time here just kind of going over what SIBO is, because that alone can cause confusion. This is a condition that's defined by an abnormal presence and amount of microorganisms that have made their way into the small intestine. SIBO typically produces gastrointestinal symptoms, and it can impact normal digestion and some nutrient absorption. So usually small intestinal bacteria are very limited. A normal small intestine has much fewer bacteria than the colon, especially in the upper part of the small intestine. Our bodies generally stop microbes from overpopulating the small intestine, but there are conditions and risk factors that disrupt these natural guardrails and can lead to things getting a bit out of control. So SIBO is known to be a symptom of some kind of disruptor, and we'll review those risk factors shortly that interfere with normal barriers for maintaining low amounts of small intestinal microbes. There are two types of microbial overgrowth, and they're characterized by the gases that the microbes themselves produce. One is, let's say, classic SIBO, small intestinal bacterial overgrowth, that's hydrogen gas producing. And the other is methane predominant SIBO, producing methane gas, but the name is actually a false classification because it's not actually bacterial, it's archaea, methanogens specifically, which aren't bacteria, they're closer to us in their biology. And because archaea can also overgrow in the colon as well. So we refer to this as intestinal methanogenic overgrowth, or IMO. But as a broad category tonight, when Faith or I say SIBO, we're referring to both of these types of overgrowth. And you can develop either one if you're at risk, or both. You can have mixed flora overgrowth, which we see. So importantly, we say overgrowth and not infection because the microbes aren't typically pathogenic, meaning disease causing. So that's myth number one here. You'll see these little gas bubbles, if you will, that have some yellow mythology, the yellow text. SIBO's not an infection, and it's also not necessarily the presence of bad bacteria or another myth of it being an imbalance of good versus bad bacteria. These microbes are generally harmless residents of your microbiome that could be normal and well controlled in another place like the mouth or in the colon, but they're not normal in the small intestine. So what's it like having SIBO? Not particularly fun. A hallmark symptom of SIBO is a lot of gas and bloating, especially after certain meals that you may have even tolerated before and start to notice some discomfort with it. It could be various fruits, vegetables, some dairy, higher fat foods, sometimes sugars and starches. We'll talk about some of those common ones soon. And SIBO can also bring on abdominal pain or cramps after eating. Another common symptom is stool changes. So having excess bacteria in the small intestine can cause interference with fat absorption, as well as with something called bile acids, which are a normal part of digestion. And that can lead to diarrhea in some people. Fat malabsorption can produce oily, floating, or light colored stools. And it can also contribute to weight loss as a symptom as well. If you have methanogenic overgrowth, the methane gas produced by the archaea often causes constipation as a primary symptom, not diarrhea. Micronutrient deficiency, also possible, specifically vitamin B12. Sometimes we'll see iron or fat soluble vitamin deficiencies. The small intestine is where most nutrient digestion and absorption happens. So if there's this overpopulation of microbes meeting the food coming in, some nutrients could be used up by the bacteria instead of by us. And many of these symptoms, importantly, would actually not be the case in irritable bowel syndrome, in IBS. So firstly, it can be mistaken for IBS. It can occur alongside IBS, but it's not IBS. And having IBS does not inherently mean you're at risk for SIBO. So there can be some mythology and confusion with that. And also, luckily, SIBO symptoms, as horrible as they are, aren't permanent. They're present only until it's successfully treated. And it is treatable with the right protocol. So SIBO is not this permanent identity that sometimes we hear patients, feeling like it is. But addressing what's caused the SIBO is an important part of this. So let's review how and when you might be at risk for this overgrowth. So lovely human body has many natural guardrails that constantly regulate microorganisms in the small intestine. So things like stomach acid and pancreatic fluids are antimicrobial. And we have these natural sweeping type waves in the intestines that move microorganisms downstream. And we have a valve called the ileocecal valve that stops microbes from moving back upwards. But there are a whole lot of reasons why this kind of checks and balances system can fail. It only takes one flaw to put you at risk. And it's not to say that we're all at risk, but the risks are vast. And I'm not going to go over every single one, but they include things like surgeries or changes to your anatomy that affect the small intestine, weight loss surgeries, resections, strictures from Crohn's disease. It could also be small intestinal inflammation like active celiac disease, Crohn's, or even from chronic NSAID use like ibuprofen or aspirin. Things affecting motility like small intestinal adhesions or conditions also that cause low stomach acid, alcohol overuse, poorly managed diabetes, or a bout of food poisoning or bacterial gastroenteritis. So there are a lot of things, but the main point is that there's lots of reasons why we could suspect SIBO if it lines up with your clinical symptoms. Some of the myths out there about what can cause SIBO are stress, an unhealthy diet, a course of antibiotics. None of these are known risk factors for SIBO. And SIBO is also not an infection. It's not contagious. It's not something you contract, but it can be caused by some disruptor in those natural protectors. So how do we test for it? The most common way to diagnose is through something called breath testing, which involves measuring changes in your exhaled breath gases that only these microbes produce in response to certain sugars that you ingest for the test. So basically, you start the breath test fasted, a baseline breath gas measurement is taken, and then you drink a solution of water with either lactulose or glucose. Those are the sugars that the bacteria can ferment. And then you breathe into a bag every 15 or 20 minutes for 3 hours. And the breath test is then analyzed for the methane and hydrogen gases produced by microbial fermentation of the sugar that you drank at the beginning. If there's a significant rise in the gases at certain time points, a SIBO diagnosis can be made. Breath testing is considered imperfect. It can have false positives and false negatives. And a lot of this can actually come from poor preparation for the test. There are some specific instructions to follow, and mistakes get made when patients prep for it. But there can also be poor test administration or improper testing methods. There are many private companies that offer this test and may not follow best practices. So we really want to be careful with testing. It's, of course, something that we offer in our office, but ultimately matching the test result to clinical symptoms can be an important part of treatment and diagnosis. So breath testing also, interestingly, even though it's the most common way we test for SIBO, it's not actually the gold standard. The gold standard is taking a fluid sample of your small intestine during an endoscopy, and then culturing that fluid in a lab to assess for small intestinal microbial activity. But this method is really rarely performed because it's very invasive for a patient. It comes with safety risks. Precision is also difficult. So it's really mostly used in clinical research settings. Here's the good news about SIBO. It's treatable. There are myths that SIBO is not curable and that it's this forever condition, but that's false. It can reoccur, but broad spectrum antibiotics can and do eradicate SIBO, and they're the only evidence-based treatment that we have for it. There are multiple antibiotics that can get used in the treatment of SIBO, and that can depend on the type of overgrowth that you have. But generally, these courses are for 2 weeks, will be taken 2 to 3 times a day. And, treatment is not always successful on the first round. Up to 50% of cases may need an additional course of antibiotics for success. But on the whole, they have up to an 80% success rate. And importantly, the efficacy of the treatment can really depend on identifying an underlying SIBO driver if possible. Also, common supplements marketed as herbal antibiotics don't have an evidence basis in the treatment of SIBO, which Faith is going to review in a little bit. And diet is also not an evidence-based cure or prevention tool for SIBO. So neither diet or supplements have been rigorously tested or proven as SIBO treatment. And we do see patients get into a fair amount of health trouble with non-evidence-based treatments that are out there. So we need to be really careful here, and we'll go through some of the research on what we know can work. So shifting to the more anticipated part, all about the diet hoopla that's out there, what to do nutritionally for SIBO. So, here just are some little gas bubbles with the most common diets or diet strategies that we hear about, that you may have heard about as well. And they're all kind of linked by one big theme, which I already gave away the spoiler, which is no single diet has been proven to cure SIBO or to prevent its recurrence. But we can use diet to help manage symptoms and to try to get you feeling as good as possible until your SIBO is successfully treated medically. The thing about a lot of these structured diets or diet changes is that diet restriction comes with quality of life issues. So we generally have to decide if the juice is worth the squeeze, so to speak. As dietitians, we're listening to your symptoms to identify patterns. And if there's a restriction that may be helpful, it's something that we're going to advise only on a temporary basis. So we'll go through a few of the most common diets and what we know about whether the restriction could be worthwhile. So I'm going to start with a diet called the low FODMAP diet, which is the most common diet for SIBO. If there was a star diet for SIBO, this would be it, but that's a stretch to say. It would be, or it is, the least restrictive diet and the one we typically see the best results with for SIBO, although it's still not a magic bullet for everybody. So FODMAP is an acronym. It stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which together describe groups of foods that bacteria break down and ferment, which is the F here, the fermentable part. That includes a lot of notoriously gassy foods like beans and Brussels sprouts and cauliflower and broccoli, but it's also foods you wouldn't necessarily recognize as gas producing, like watermelon or honey or pistachios. So we have reason to believe that people with active SIBO can develop temporary sensitivity to FODMAP foods. The diet was actually first created a couple decades ago. It rose to fame with published evidence for people with IBS. It's one of the better studies now for IBS. It has good clinical evidence for reducing abdominal pain, gas and bloating, and stool frequency and urgency, particularly for people with diarrhea predominant IBS. So there's evidence to show this diet can reduce some of the key symptoms that overlap with SIBO, and that includes the gas, the bloating, the abdominal pain, diarrhea. So reducing a FODMAP load is thought to bring down the fermentation load by avoiding these foods that the excess microbes in the small intestine have access to, and where there normally wouldn't be that fermentation happening. But there haven't been clinical studies evaluating the effects of the low FODMAP diet on SIBO management on the whole. So we're still using this as a very customizable tool. We don't have evidence to suggest that it can treat SIBO. We have evidence and experience in clinical practice that it can impact SIBO symptoms. So, there's some confusion around this diet that it would be a long-term diet, which it's absolutely not and was never designed to be. And it's a temporary diet plan that can be used also partially, right? It doesn't necessarily have to be used as a strict elimination diet. I use a sort of light or gentle, partial form of it with patients often. FODMAPs also don't have any bearing on the growth or reduction of the microbial population in the small intestine. So this idea that FODMAPs starve SIBO or help or hurt antibiotic treatment is unproven. It's really about using this to help manage symptoms until we can get rid of the SIBO medically. And so this next diet, the elemental diet you might hear about in connection to SIBO, is an exclusively liquid nutrition diet with nutrition formula that contains nutrients in an easily digested form, basically pre-broken down proteins, fats, and carbs, and micronutrients, vitamins, and minerals. You typically mix the formula with water, and that comprises all of your meals without taking in any solid food. It's definitely the most restrictive type of diet that can be recommended or prescribed. As you can imagine, or if you've experienced it yourself, it can impact quality of life in a really big way. And it's something that we really reserve for the most compromised gastrointestinal cases. When it comes to SIBO, this was studied in 2004 with a small group of patients that were diagnosed with IBS and SIBO, and they found that there was a 66% improvement in SIBO symptoms and a normal breath test result in 85% of the group just 2 weeks later. The big issue with this research here is that there was no follow-up to assess SIBO status or symptoms afterwards. So we don't know what was sustained, if this was a temporary result or what. There hasn't been any kind of quality research done since, so we would be on really shaky ground to recommend the diet for SIBO. But the practical and nutritional implications are also a really big part of this, taking away solid meals and often incurring a pretty large financial cost for this, and drinking shakes that might not be very palatable. And there's this risk of malnutrition in the way that this type of diet gets used for SIBO now, because it's translated to this idea that any liquid nutrition can replace a full diet, which is not true. Bone broth is not a nutritionally adequate diet. I've seen juice cleanses, I've seen milk fasts, I've seen other inadequate formulas that can present a really serious health risk if that is the only form of nutrition coming in. And, it's totally possible that liquids can make you feel better for a variety of reasons, but we don't need to resort to liquids only. We do have other diet tools like fiber and texture modifications to try to maintain diet flexibility without quite getting to that level of restriction. So not a diet with great research for SIBO, and also a level of restriction that's generally unjustified.
Okay, I will take it from here. So the next diet we often, hear about is the low fermentation diet. So the low fermentation diet was created in the early 2000s by Dr. Mark Pimentel at Cedars-Sinai, and it has two essential parts. So the first part is to restrict foods that contain highly fermentable carbohydrates, which are not easily digested by humans, but are easily digested by bacteria. And the second part has to do with meal timing, which is to space meals 4 to 5 hours apart to allow for the gut's cleansing process called the migrating motor complex. Right, at first glance, this diet seems pretty similar to the low FODMAP diet, with the elimination or reduction of highly fermentable carbohydrates. However, what is considered highly fermentable according to the low fermentation diet actually differs quite a bit from the low FODMAP diet. So for example, as on the slide, you can see onion and garlic and mushrooms, which we know are some of the highest FODMAP foods, are actually permitted on the low fermentation diet. And there are also some foods that are excluded from the low fermentation diet, such as oatmeal and salads, that are permitted on the low FODMAP diet. So in general, the low fermentation diet is not very nuanced, and therefore it may not provide optimal benefit for symptom management with the most liberalized diet possible. And that's always what we're looking for, right? The most liberalization possible, the least restriction possible for optimal symptom relief. And as far as the second part here regarding meal timing, we have these cleansing waves that begin about 90 minutes after a meal. They usually run for about 4 hours, but they can keep going until the next meal happens. So there are, 1 to 2 studies that looked at these cleansing waves in SIBO, and these studies determined that in some SIBO cases, there are fewer or no cleansing waves at the 4-hour mark of fasting. And, even if we accept these results at face value, in that some patients with SIBO are not experiencing these cleansing waves, what does that really tell us about the utility of meal spacing, right? If there's a mechanism that's already not working properly, what is meal spacing actually going to change? How is it actually going to help? We're not really sure, but we can say that there's not quite enough evidence to recommend meal spacing for SIBO patients. And beyond all of this, the bottom line is that we just don't have studies evaluating, the use of this diet. Next slide, please. And so another diet that we see is the specific carbohydrate diet, or SCD for short. It became popular in the 1980s as a way to manage inflammatory bowel disease. It's a diet that restricts all grains, starchy veggies such as yams and potatoes, most dairy with the exception of hard cheese and homemade yogurt, and all sugar with the exception of honey. And so again, this diet does tend to provide some symptom relief because it happens to eliminate many high FODMAP foods since it's a low-carb diet. However, the SCD also permits some high FODMAP foods, certain fruits, veggies, honey, legumes, which will likely not be well tolerated in people with SIBO. So essentially, the SCD diet may be unnecessarily restrictive when it comes to carbs and sugar, so we typically don't recommend it in our practice. And, for time's sake, we're not going to be able to go through each of the diets you saw on Suzy's initial slide, but there is one called the SIBO diet, also known as the biphasic diet, which basically combines the low FODMAP diet with SCD, and it's very unnecessarily restrictive. But the common theme we typically see across the board is that most diets out there, claiming to manage SIBO symptoms are usually helpful due to the inherent elimination of some FODMAPs rather than due to the actual principles of the diet itself. Next slide, please. Okay, so time to switch gears a little bit. I think this is probably where, most folks might have some questions. When it comes to supplements, right, these are just a smattering of supplements from Dr. Google, which supposedly everyone recommends for treating SIBO. And, something we see in our practice, anecdotally, right, when these supplements are mentioned over and over and over again, it sort of gives the impression that they're part of this standardized protocol for treatment when really they're not. So, people will often refer to this one particular 2014 study that seems to suggest that herbal supplements are an effective treatment for SIBO. But if we dive deeper into the study, if we look at the study design, the recruitment of the study participants, the data analysis, and the subsequent conclusion, we actually see that in the study, the criteria for diagnosing SIBO was not standardized. A lower dose of rifaximin was used than is standard in clinical practice, and the results were not statistically significant. And so this means that there would be a very low chance that the results of this study would be replicated in a larger population of people with SIBO. Right? And so that's why it's really important to read beyond the headlines and go to professionals rather than, Dr. Google or, Joe who told you something that he read from, a listicle. And so as far as we know, there are no well-designed studies that suggest that any supplements are beneficial in treating or preventing SIBO. So I will talk about each one of these, in each of these gas bubbles here, talking about the evidence or really lack thereof for each to just drive home that point. Next slide, please. Okay, so we will start with allicin, which is also known as garlic extract. It is a supplement that may actually help to reduce some risk factors for cardiovascular disease. And there's also some mixed evidence in terms of protective effects against various cancers. But when it comes to SIBO, right, the claim is that allicin is an herbal antibiotic that can kill bad bacteria in the gut in lieu of prescription medications. But what is the evidence? So there is very limited evidence that allicin could help improve the effectiveness of a prescription antibiotic. This research was done in vitro, however. That means it was done in a test tube. And we really cannot apply these results to, that potentially of a human body. So we conclude that we don't have, any current evidence to support the use of allicin as a SIBO treatment, either on its own or in combination with other herbal supplements. Next slide. Berberine, another commonly discussed supplement that we often see, which is a substance found in a variety of plant species. It has a long history of use in traditional Chinese medicine and Ayurveda to treat infections, diarrhea, and it's also used for the management of blood sugar and high cholesterol. There's actually fairly good evidence to suggest that berberine can have a significant blood sugar lowering effect. However, it has not been studied with respect to SIBO, so there's no evidence to indicate whether or not it has an effect. And I do want to point out that there is a forthcoming study, as you see on the slide here, called Berberine and Rifaximin Effects for Small Intestinal Bacterial Overgrowth, brief SIBO for short. And I just mentioned that because I wanted to highlight the fact that we do stay abreast of the current research, and we're willing to adjust our recommendations if and when we have sufficient evidence to do so. Next slide. Okay, so oregano oil, I would say probably the supplement we get the most questions about. It's been recognized for its antimicrobial activity and antiviral and antifungal properties. And similar to allicin and berberine, the claim is that it can kill bad bacteria in the gut in lieu of prescription medications. So what does the evidence say? Research has suggested that oregano oil can have a powerful inhibitory effect against certain fungi and bacteria in vitro, right? Again, just like we saw with allicin, we cannot apply test tube results, so to speak, to the human body. So along with the prior two supplements we just discussed, there's no evidence to support the use of oregano oil as a SIBO treatment. Next slide. Okay, so fiber supplements are another broad category touted or potentially touted as helpful for SIBO. There's one study that looked at a particular type of fiber supplement called partially hydrolyzed guar gum, or PHGG for short. It's a type of soluble fiber that can be really helpful in regulating bowel function. Regular Girl or Sun Fiber are potentially two brands you might recognize that contain this fiber. So there was one 2010 study that sought to explore a potential benefit of PHGG in SIBO treatment. There were 77 study participants that were diagnosed with SIBO. They were randomized into two groups, the control group who received rifaximin only, and the intervention group who received rifaximin and PHGG. And so the claim, according to the results, was that rifaximin and PHGG together seemed to be a more useful treatment than rifaximin alone. However, if we look at the evidence, while SIBO eradication and clinical improvement rates were better in the rifaximin and PHGG group, the results were not statistically significant. And just to be clear here, the eradication refers to the improvement in the breath test values, while clinical improvement refers to the patient's reported symptoms. The study also didn't use the standard dose or length of treatment for rifaximin that we typically see in clinical practice, and the study didn't do any follow-up to look at recurrence rates. So, what we can kind of conclude here is that, I would say we have insufficient evidence to recommend PHGG as a complementary SIBO treatment. Next slide, please. Okay, so just so you know, the last bit of supplements we will discuss are probiotic supplements, but before we get there, let's talk about enzymes. Right, so enzymes are specific to their targets, so they only work if they're the right enzymes for the job you need them to do. So taking a random cocktail of enzymes for SIBO is likely not to do much at all. But that said, there are two examples of enzyme blends on the market, one called FODzyme, the other FODmate, which are specifically designed to break down high FODMAP foods. We often use them in our practice to help provide patients with some symptom relief in situations in which any type of restricted diet wouldn't be indicated, for example, in eating disorders or malnutrition. So I've broken down the components of each individually here. And as you can see, both products contain lactase, which breaks down lactose in dairy products, as well as alpha-galactosidase, which is the enzyme that breaks down galacto-oligosaccharides, GOS for short, which are found in beans and cruciferous veggies, for example. The products are quite similar, and often patients will choose one based on whether they prefer a powder or a pill. Fodzyme is a tasteless powder that's sprinkled on your meal before your first bite, while FODMATE is a pill that you swallow before your meal. And I do want to point out, I think it's of interest that there are no enzyme products yet that help to break down polyols, right? That's the P in FODMAPs. Those are sugar alcohols, but Kiwi Sciences, the company that created Fodzyme, is actually hard at work on this. So should be interesting to see in the future. Next slide, please. Okay, coming to probiotics. So, I think most of what you might read about the role probiotic supplements play in SIBO treatment, if any, is largely based on opinion, not evidence. So I really wanted to do a little bit of a deep dive here to take a look at the evidence. So we have a 2018 comprehensive meta-analysis that determined that there was no evidence that probiotic use prevents SIBO, but alleged that probiotic use could potentially treat SIBO. So you can see here on the slide in italics, this was the conclusion from the paper itself. Seems, pretty straightforward, right? If we just take that at face value. But if we actually look at the studies that were included in this meta-analysis, we see that there are way too many limitations and studies of poor quality to really be able to accept this conclusion. So, for example, of 7 probiotics alone studies, 5 were not statistically significant, and of 2 probiotics and antibiotic studies, 1 study did not have a control group, and the other was not statistically significant. And, additionally, there wasn't a continuous use of the same types of probiotics, right? Whether they were single strain or multi-strain, what strain, right? Some studies didn't disclose the strain. So we don't have any way to, we don't have any specific recommendations here. So, right, that said, beyond reading sort of the conclusion or the headline, we can really see that there is no evidence that probiotics treat SIBO. Next slide, please. And we actually have a more recent study, 2024, right, this year, yes, that explored whether herbal supplements and probiotics could be a potential complement to antibiotic treatment in SIBO. So although the authors claimed that there was a greater clinical response in the intervention group, that's the group that was given antibiotic treatment plus herbal supplements and probiotics. Again, kind of a common theme we're seeing is that the results were not statistically significant, and there was no difference in breath test resolution between the 2 groups. Also, research suggests that probiotic use may actually increase the risk of developing SIBO and inducing a recurrence. So generally in our practice, we don't recommend the use of bacterial probiotics to manage SIBO. However, if there is a concern for antibiotic-associated diarrhea during SIBO treatment, or if patients are just interested in taking a probiotic, Florastor, which is a yeast probiotic, so sort of a different category, can be really helpful in that instance. Next slide.
So I'll just jump in to talk about some of the additional dietary considerations after SIBO treatment, right? So these are some of the things we've spoken about during, but we do get a lot of questions about what you should do after a course of probiotics, or how to come off of maybe a restricted diet that you were following, or foods that maybe you didn't tolerate before, and now we're trying to sort of reassess how things are feeling. So most importantly, thinking about gut microbiome after a course of antibiotics, probiotics are not our general recommendation. It's actually fiber in all of its dietary forms, from different plant foods that can be really helpful. Bacteria love fiber. They feed off of different types of fiber particles. Different bacteria prefer different types. So getting a diverse array is important. If you were restricting fiber for whatever reason, if various plant foods weren't feeling good, then it's just gradually trying to ease into it to support your gut health. And we actually really want to see some resumption of your normal diet so that we can test out food tolerance, right? So if you were on a low FODMAP diet, if you were eliminating any foods that you found to be triggering before or during your SIBO treatment, after the treatment is a time to say, let's add those foods back in. Hopefully you're feeling better and we can say, how are things feeling at this point? Can you tolerate those individual foods or meals? The goal is to get your diet back to what it was previously. And if foods aren't feeling good, we kind of want to investigate what could be going on there. There's so many different layers of and types of diet restriction out there for SIBO. And, we're really focused on nutritional adequacy and also supporting a healthy relationship with food. These are never diets that are meant long-term or changes that are meant long-term. They're really addressing how you're feeling when we know there's some active microbial overgrowth. And beyond some of the diets that we talked about, there's other diet tools that we use. We modify fiber, we modify texture, we'll use other types of over-the-counter supplements to address specific symptoms that you might be feeling, because not everyone experiencing SIBO has it experiences it in the same way, right? So so the individualization is really important here. And just again, with some of the mythology that we hear, that it's best to follow a low FODMAP diet, right? Because we know that diet can be helpful, and then we'll see patients stay on it for indefinitely until they're told not to after treatment. And that's really not the goal. We should actually see that FODMAP tolerance improve. And the same would be true for carbohydrates in general. If a lower carb approach was feeling good during or before SIBO treatment, we want to ramp up that carb intake pretty quickly afterwards. And so just to summarize some of the key takeaways here before we get to questions, most important thing to know about nutrition and small intestinal bacterial overgrowth is that no diet has been demonstrated to cure SIBO, prevent SIBO, or to manage any type of recurrence. The role of diet here is really to manage symptoms until your SIBO is treated successfully, always taking into account each patient's specific needs and risk factors for reoccurrence. Broad spectrum FODMAP digestive enzymes can be one type of supplement to help provide some symptom relief, and also over-the-counter products for specific symptoms. Like I mentioned, that individualization piece, we might use laxatives for constipation, simethicone for gas, bulking fiber products for diarrhea. Those types of interventions can work to also partially improve symptoms a bit until treatment is successful. So let's discuss some questions.
Okay, thank you guys. I appreciate it. There have been a lot of questions. First, let me again remind our listeners tonight that if there are questions of a personal, individual nature, I'm not going to respond to them. I said that at the beginning, but anybody may have joined late. So if your question went unanswered and it's about yourself, that's why. Got a lot of questions about what someone should be eating while they're taking the antibiotics. And does diet choice matter while you're taking the antibiotics? Does it reduce or affect the efficacy of the antibiotic therapy?
So I would say diet matters and also doesn't matter in this case. So diet matters because we might consider certain diet changes to help make you feel better, to hopefully just get you feeling better as soon as possible until you finish the antibiotic course. Diet affecting the antibiotics themselves or the populations of microbes in your small intestine is unproven. So nothing you eat is going to change the course of small intestinal bacterial overgrowth, but what you eat could cause you to have some symptoms or not. And so that's a choice as, to the extent of your symptoms, if you want to intervene or not.
Right. I would sort of add to that, I sort of ask my patients, like, how horrible do you feel? If you really feel bad and that it's really hard for you to get through the day, to go to work, then I think, it makes sense to talk about the low FODMAP diet or to talk about some elimination while you're getting the treatment to help you manage symptoms. But if you're sort of, I also have patients who say, well, I've been feeling this way for so long, I can manage it for another couple of weeks. And so I think it really depends, on the person, on the patient, case by case basis.
I'll also answer or add to that from the physician's perspective. You can't really take high calcium foods with quinolones like Cipro or Levaquin or doxycycline if those are used, just because they bind to that. So thank you. We got a lot of questions about the relationship of COVID to the development of SIBO. That's very much outside sort of the scope of our talk, but it came up a lot. With your permission, I'll field that if that's okay. When you guys were talking about the potential underlying causes and providing a very thorough list of things that doctors should be looking for as to why a patient got overgrowth, we know that many people develop immunologic or motility changes in their gut in response to infection. That was true before COVID existed. That is true from COVID. That is true post-COVID. And COVID itself, it is not an exception to that. So to the extent that there may be changes in gut movement that predispose to developing SIBO, yes, COVID could do that. But again, that is not unique to COVID and shouldn't really be thought of as unique to COVID. Okay. Got an interesting question that maybe you guys know off the top of your head. I couldn't answer personally because I couldn't find the answer. In terms of using FODzyme or FODmate, are they a substitute for Lactaid? Are they a substitute for Beano? Are the doses equivalent? Like, can you leave your Lactaid home and use your FODzyme?
I believe so. I would need to triple check to confirm, but I'm fairly certain that is the case.
Yeah, okay. That was what I thought. But
So I think it's the same dose for Beano, which would be alpha galactosidase. That's in some other products like Beanzyme as well. I don't know the lactase dose off the top of my head, but I will say a common flaw with taking a lactase enzyme. So Lactaid is just the brand, but there's many companies that make it, and the FODMAP enzyme, like FODMAP, FODmate and FODzyme include lactase, just to clarify for others. I generally look for a minimum of 9,000 lactase units in a product as something that would be suitable for a lactose-rich meal. But also just knowing that the FODMAP enzyme blends, so the FODmate and the FODzyme, would be sort of overkill in that scenario. So like if you know you're really only chasing lactose as your issue, or beans as the issue, then I would just kind of go for that product, and they're going to be cheaper than getting this kind of bigger bull for a smaller problem.
Thank you. That's helpful. One or two questions that we got here about the role of fasting during the treatment of SIBO, or as a risk factor for SIBO. And I know it was touched on in the discussion of the low fermentation diet, but maybe you could expand a little bit, please.
Sure, yeah. So, this idea of the motor migrating complex that kind of cleanses the gut after eating, there's really, if somebody's meal pattern is already such where they happen to have, 4 hours between meals, that's fine, but we don't really have enough evidence for me to recommend to somebody who perhaps has more of a grazing type meal pattern. Maybe they're eating every 2 to 3 hours, for me to say, okay, let's change that. Let's kind of have you have longer fasting periods. So in terms of how we would use that when it comes to what we recommend, if somebody's already doing that, fine, but again, not enough evidence to recommend it.
And I would also just add that I hear from a lot of patients with SIBO that they feel best fasted. They feel best when they don't eat. That's when symptoms can be at bay. And that doesn't mean that fasting is the answer. There are still foods we can find for you to tolerate in the meantime. Nutritional adequacy is still really important. So I don't want anyone to think that that is what they need to resort to, or because they notice they feel better that way. There are other options dietarily, for sure.
Yeah, I'll definitely just sort of chime in and echo that as well, that part of our goal in our practice, both as physicians and as dietitians, is to help you enjoy eating and eat as much as you want and whenever you want and whatever you want, and feel good doing it. We try to shy away from being overly restrictive for most of our patients as often as possible. Fasting, as Faith said, can allow the migrating motor complex to clear your bowel, but there's really no reason to suggest that long periods of fasting, 18 hours or whatever, is required. The MMC is normally thought of as a 3-hour phenomenon. And so, fasting between lunch and dinner may be sufficient depending on your workday. So we're going to end here. We're coming to the end of our hour. Again, thank you both for a terrific presentation. I hope we were able to clear up and dispel some myths and support some of the evidence-based options for non-pharmacologic management of SIBO symptoms. As a doctor, it hurts me to say, but not everything's about the pills. And I think this is a great example of using the right set of tools non-pharmacologically can actually make a big difference in helping your patients to feel better. To that end, again, I apologize. A lot of questions about antibiotics, which are very much beyond the scope of tonight's talk. I didn't answer those, and as I said, I didn't answer any personal questions. This talk will be up on our website for re-review. And thank you very much.
Thank you all for joining.
Thank you all for joining. Have a great night.
Good night.